All right, so hypertension is one of the aspects in your medical profession. You have to be very familiar managing patients with hypertension, as is one of the leading causes of morbidity and mortality in the United States. We're going to create a scenario where you're going to be the patient, Cameron, coming into my office.
Okay.
And let's talk about first, how do you establish the diagnosis of hypertension? A lot of the questions on the boards are going to want to trick you, and they're going to want to have you prescribe medications up front. What I want you to do is to understand that the diagnosis of hypertension requires at least 2 separate blood pressure readings. And the new guideline, I don't know if you're going to be, usually the boards are very straightforward. When there is a change in practice, I think it takes some time before they implement those questions on the board. But I want to make you aware about the most current evidence, how we diagnose hypertension. Now the diagnosis of hypertension requires that we do the standard of care, which is a 24-hour ambulatory blood pressure monitoring. Have you guys seen the equipment? I think Dr. Ben-Zur has one here in the office. And it's just basically the same concept as being hooked up to a Holter monitor for 24 hours. You can set it up to, in my patients, I usually set it up for like a couple of readings during the day and 1 reading at night, because you don't want to have this thing going off every 30 minutes. But the utility of the 24-hour ambulatory monitoring for your boards, it basically comes down to 3 things. Number 1, the diagnosis of white coat hypertension should always be made with a 24-hour ambulatory blood pressure monitoring. In other words, if you have a discordant home reading and office reading, that's an clear indication to order a 24-hour ambulatory BP monitor. The second thing is that some patients are diagnosed with masked hypertension. In other words, is that they come to the office and the blood pressure is normal in the office, and yet they're having a lot of hypertension. In particular, at night. Do you guys know which patients become particularly hypertensive during the night? Patients with sleep apnea. And there is another useful piece of information that we gather from the 24-hour ambulatory blood pressure. I'm going to call it the ABMP, ambulatory blood pressure. I don't know who's calling me, but sorry, I can't answer. So basically, we call that, physiologically, we all have a dipping pattern. And the dipping pattern means that our systolic blood pressure drops between 10 to 20 points during sleep. So when you have a non-dipper if they give you a board question and they show you a guy who's non-dipping, that's OSA until proven otherwise. So always remember that, because that's going to be on your boards. That's, if you have a patient with that kind of pattern, that patient needs, the next step in the management is order a sleep study. Okay? So that's indication number 2. And 3, which is the most recent recommendation, is to establish or to confirm the diagnosis of hypertension. So in other words, the new guideline favor doing this test and not just relying on a couple of blood pressure readings. Obviously, it's not feasible because it's costly. Not every practice carries the equipment. And they also give an alternative. In this new guideline, they also give you an alternative, which is having the patient educate the patient about the proper technique. You know, we all know that the arm needs to be at the heart level. Patients should not have their legs crossed, empty bladder, empty bowels if possible, empty stomach, no caffeine. You know, typically we do 2 readings or 3 consecutive readings, and you use the last one as the real reading. And basically we tell the patients to document in the absence of the ABPM. But that's basically on your boards. The diagnosis is 2 readings in the office. The most recent guideline includes ABPM or confirmation at home. So the next thing they're gonna try to give you on your boards is a patient who, okay, let's say that you did 2 readings and your blood pressure came both times 150 and the other time 148, despite okay, let's say the 148 and 155. What is the next step in the management? What do you want to advise this patient?
So you can do the 24, those are both in the office? Sorry.
These are both in the office, 2 separate days. So they're going to give you options. So number 1, start patients on hydrochlorothiazide. Number 2, give the patient a beta blocker. Number 3, recommend lifestyle modification. Number 4, let's say observe for now.
Okay.
What would you do?
So you have to confirm the diagnosis, and so you have the option of doing the ambulatory blood pressure monitoring for 24 hours,
Or the home.
educate the patient and then have them take it at home.
Right. And then let's say that you do have a diagnosis of hypertension. What's the next step in the management of these patients?
Probably education, and then continue to monitor at home.
Yeah. Do you jump into medications right away, or you want to give them a try of lifestyle modification? So on your boards, don't let them trick you, because most people are going to say, "Oh, he needs a thiazide." You can always try them. There's no danger of like leaving someone in their 150s. And you use your clinical judgment. There's really no guideline that tells you if I have a patient showing up with systolics in the 170s and I already confirmed the diagnosis, I'd probably just start the guy on one agent at least, if not two. But for those patients with mild hypertension, you want to give them the opportunity to have lifestyle modification, which include
like salt restriction.
Salt restriction was the American Heart Association statement in 2008.
Less than 2.
Less than 2,000 milligrams. What else is the definition of lifestyle modification? What else?
Like exercise.
For how long? For how many times a week?
Like 30 minutes.
I think.
At least 60 in a week.
Yeah, I think at least 5 days a week, like no less than 30 minutes. So that's like exercise, the more the better.
Yeah.
And what's the other recommendation that is effective lowering blood pressure?
Quitting smoking.
The smoking, they've done studies. I mean, it's always good to recommend that we stop smoking, but it's not necessarily directly implicated. It may be, but you know, it's not. On your boards, they're probably going to ask you about weight reduction, increased activity, and dietary sodium reduction. There's some diets that are associated with better blood pressure control. I don't know if you guys heard about the DASH trial. Yeah, the Danish diet, and I forget what the name of the study is, but basically they were successfully able to drop the systolic blood pressure reading like a delta of 8 millimeters of mercury for those patients that were adherent to a Mediterranean type of diet. So those are the things, but on your boards they're always going to give you like a little thing that you can follow. Mm-hmm. So the most common one, what are the most common over-the-counter medicines associated with hypertension? You're going to be prescribing them like candy, especially you, Cameron. Mm-hmm. Which medications are associated with hypertension? In fact, you shouldn't use them if you have a person with uncontrolled hypertension.
That cause high blood pressure?
And they're over the counter, yeah.
Caffeine?
Caffeine can cause, but it's not caffeine. You're going to be prescribing them a lot.
So Excedrin has caffeine in it?
Well, what else is in Excedrin?
Like pain relief things.
Which one?
Like NSAIDs.
NSAIDs. You said it, NSAIDs. NSAIDs. I'm going to give you my 2-minute talk on NSAIDs. NSAIDs are very good medicines. However, you need to understand who you should prescribe and who you shouldn't prescribe. I'm going to give you examples. So the FDA in general recommend that we stay away from NSAIDs in people older than 60. That's not an absolute recommendation, but you need to use your judgment. If you have an elderly person, definitely don't use it. Like let's say 70 and older. But the FDA, the textbook definition is greater than 60, use with caution. You never use NSAIDs in patients with chronic kidney disease, whatever the stage is, even if it's a stage 1 with like protein active urine sediment, those patients you do not want to prescribe NSAIDs, because NSAIDs are associated with, in the kidneys, are associated with many different things. Number one, the most common one is vasoconstriction, because by inhibiting the prostaglandins, the prostaglandin is the natural vasodilator of the efferent arteriole, and if you prescribe an NSAID, effectively you're causing like a prerenal state, and you're cutting down circulation to the kidney. But going further, you can develop secondary membranous nephropathy associated with NSAIDs. You can also develop minimal change disease associated with NSAIDs, and you can cause a rare cause of acute kidney injury called acute interstitial nephritis. I don't know if you heard about it, but more commonly seen implicated medications are beta-lactams, PPIs, and NSAIDs. And we're going to talk about it when we do the clinical cases. Okay, so But in general, do not prescribe NSAIDs in patients with kidney disease. You don't want to hurt the patient. You don't want to upset the nephrologist taking care of the patient. And another scenario is like you do not use NSAIDs in patients with heart failure for the same reason. NSAIDs are actually, I don't know if you guys remember, you're probably too young to remember this, but back in the 90s, we actually have like an incredible amount of COX-2 inhibitors, cyclooxygenase 2 inhibitors, and a lot of them were pulled out of the market. And the only one that still remains is Celebrex. But we have Vioxx, we have, forget what the name, there are like so many of them because they were associated with increased risk of cardiovascular mortality, like people, they're having like heart attacks and strokes. So in general, patients with like cardiomyopathy, you don't prescribe it because of the same reason. Those patients already have a compromised renal perfusion from the cardiorenal syndrome. If you prescribe something that is going to decrease further the renal perfusion, the patients are going to be in trouble. They're going to get acute kidney injury. Okay, so that's another important recommendation. And you probably know the other ones for patients with bleeding ulcers or history of peptic ulcer disease is not a good choice. And lastly, for those patients with uncontrolled hypertension, they're not good choice medications. So when you're in the urgent care ER, just take a minute, think about the things that I just told you, like, okay, is NSAID probably a good choice? If patients don't have any issues, they're healthy, and you know that their renal function is normal, go for it. Nobody's going to blame you. You know, that's actually they're very good medications. And because of physicians moving away from prescribing these medications, we created another problem, which is the opiate epidemics that we have in the United States. Like, everybody's prescribing opiates, which is not good either. But at least think about those that I mentioned: kidney disease, heart failure, hypertension, and peptic ulcer. Okay? Very good. So on your boards, always, on your question, always assess if the patient is on NSAIDs. Okay, now I want to hear which patients are also associated with bad outcomes. I'm sorry, which other medications that are over the counter are also associated with hypertension. If I have a cold,
like Sudafed.
There you go, Sudafed. And it's a big deal. So by the same token, do not prescribe Sudafed in the elderly or in patients with hypertension. They're going to have a hypertensive emergency or hypertensive urgency. And believe it or not, patients that are abusers from Afrin, like any topical alpha agonist, they actually develop severe hypertension as well. So oxymetazoline, Sudafed and all those stuffs, stay away. Pseudoephedra, ephedrine, all that stuff can cause. Okay, so, but there are also prescription medications associated with hypertension. Do you guys remember which one is the board favorite? I'm gonna give you a hint. They give you a 23-year-old woman that was basically seen in the office with systolic blood pressure in the 150s, come back to the office in the 160s.
Birth control.
Birth control. So you're gonna get that question guaranteed. So estrogen-based contraceptive regimens. That doesn't happen with progesterone-based contraceptive regimens. Okay? So estrogen is always a board favorite. And if you guys end up going into internal medicine, you need to know this. I'm going to mention it because it's useful for your boards. But there are other medications that are associated with hypertension, sometimes severe hypertension. One of them is EPO. You guys know what EPO is?
Erythropoietin.
Do you guys know why we use EPO?
For anemia.
Cancer.
Well, actually, it's not indicated for anemia related to cancer because it's a growth factor. It can actually make cancer worse. But hematologists use it for a lot of different reasons, like myelodysplastic syndromes. Or.
Mm-hmm.
But who uses EPO the most? Which profession?
Athletes.
Lawrence Armstrong.
Mm-hmm.
But which field we use a lot of EPO?
Like with sport?
My field. Actually, EPO really transformed the way we practice nephrology all over the world. Back in the 80s, we didn't have erythropoietin stimulating agents, and patients, end-stage kidney disease patients, were dying from transfusion-related complications like iron overload and infectious diseases until Amgen, which back then was a garage company in Northern California in San Francisco, and they discovered and they created the patent for this drug, and it became one of the wealthiest companies all over the world. So back in the 80s, back in the late 80s, 90s, they were pushing EPO for almost everything in medicine. They were like, oh, you're critically ill in the ICU, you're gonna get EPO. Oh, you have anemia for whatever reason, you're gonna get EPO. Oh, you have renal failure, let me give you EPO, we're gonna normalize your hemoglobin. And the studies actually, they were so concerning that the studies were terminated prematurely because they were able to demonstrate that normalizing hemoglobin in patients carried a significant risk of strokes and heart attacks. So the recommended hemoglobin target for patients with kidney failure is 10 to 12. And we have very strict guidelines to maintain those patients in that narrow window. If the patient's hemoglobin is overcorrecting, you need to stop it right away. If you don't stop it and the patient is normalized and they get a stroke, that's malpractice. So creates a little bit of anxiety between nephrologists and nurses because you have to be very vigilant on these patients getting EPO. Another thing that is important to know is that you cannot administer EPO when the patients are severely hypertensive, because EPO causes more hypertension. So if systolic blood pressure is greater than 165, we're not supposed to give EPO. So EPO is one of the medications associated with hypertension. We have a lot of anti-psychiatric medications, like one of those newer, like Effexor or venlafaxine. Those serotonin inhibitors that are also adrenaline or norepinephrine inhibitors, they can cause severe hypertension. Yeah. Right. And on your board, they may give you that typical case of a patient eating like cheese or wine and taking the monoamino oxidase inhibitors, and eating a diet rich in tyramines, I think that's how it's called, and then having a hypertensive emergency. So just look for that one as well. And we also have a couple of medicines that are very useful in transplant medicine. They're called the calcineurin inhibitors. Have you guys heard about tacrolimus and cyclosporin? So I use them a lot because that's how we treat glomerulonephritis, and that's how we treat solid organ rejection prophylaxis. We use those medications, but both of them can cause resistant hypertension. Perhaps cyclosporin more than tacrolimus. But those are medications that are also associated with uncontrolled hypertension. And let me think. There's some other cancer drugs that are very specific. That one of them target the VEGF pathway, the vascular endothelial growth factor, like Avastin, which is FDA approved for ovarian and breast cancer. That stuff can cause severe hypertension. There's another drug called Sutent, which is also an inhibitor of, I can't remember the pathway. I'll tell you in a second.
That's the brand name?
Sutent. Sutent is the brand name. And the pharmacology, basically, there is an anti-angiogenic agent, and it's a kinase inhibitor. So it inhibits multiple tyrosine kinase, including VEGF, resulting in decreased blood vessel formation, tumor growth, and cancer progression. These medications can actually cause severe hypertension. But I don't think you need to know this, but I'm just throwing you like for your boards, you need to know OCPs, NSAIDs, and perhaps those EMAO. Right, yeah, some of the psychiatric meds. Okay, so let's say that you gave me an opportunity and I exercised and I lowered my weight and I started eating low sodium. Oh, by the way, before we move on, this is a very important concept. That's what I call pseudo resistance, and you need to always assess for that before you start escalating in the management of these patients. So how do you assess for sodium consumption? What kind of questions do you want to ask me? I'm your patient, I'm in your office, and you want to understand my sodium consumption.
Ask you how much of your food is packaged beforehand.
Very good question, because studies show that more than 80% of the sodium in our diet come from processed foods. TV dinners, like frozen dinners, like processed meats, like ham and all that stuff. A lot of the sodium comes from there. Most students, when I ask this question, they tell me "Oh, do you add any sodium to your in the table?" And most patients are going to say no. But another intelligent question to assess whether or not someone is following a sodium restricted diet is, how many times do you eat out? Simple question. We all know that that's how they make food tasty, by adding sodium. So if someone is eating daily out, forget it. It's impossible that they're going to be following a sodium restricted diet. I want to share with you a story on a patient that there is a test. Actually, if you want to assess for the amount of sodium that somebody is ingesting, you just order a 24-hour urine sodium and you multiply that by the molecular weight of sodium, which is 23, and that makes it into milligrams. But I did order on a patient who was having recurring calcium oxalate kidney stone formation, and you guys know that we recommend low sodium diet for those patients. So the lady kept forming kidney stones, and I was just puzzled, like, this lady's taking a thiazide, she's telling me she's following a low sodium diet, why is she forming more and more kidney stones? So I asked her to do the test, and she was very, very, firm, like, I'm following a low sodium diet. To my surprise, no, to her surprise, not my surprise, I suspected it, the lady was having like 7,000 milligrams of sodium. She was exceeding the recommendation by almost 3 times. And she thought she was doing a good job. So the take-home message for you guys is following a sodium restricted diet is very difficult. And clinical studies have shown that the average sodium consumption by a person in the United States with our Western eating habits is about 4,800. That's the average. When they do population studies and they're going to measure how much, it's 4,800. So you're already exceeding, and we're not talking about those that love salt or they eat poorly. We're talking about general population. Yeah, so that's a very important recommendation. So ask those questions. Okay, let's say that we all agree I have hypertension. We did everything that we were supposed to. Good technique. I don't have any white coat hypertension, whatever. So what are you going to do for me? What are you guys going to do for me?
You're diagnosed with this, start medication, if lifestyle failed.
You're going to diagnose with hypertension. It's always a good exercise to think about, is this patient primary hypertension or secondary hypertension? So primary hypertension, we used to call it idiopathic hypertension. We don't call it like that anymore. And primary hypertension accounts for more than probably 90% of the cases. I would say probably 85% of the cases of hypertension. We don't have a clear explanation. Those patients typically they have a family history of hypertension. Those patients usually they tend to respond to monotherapy or perhaps 2 agents. And then we have the secondary hypertension, which is a complete book chapter in medicine. And I'm gonna be mentioning the differentials so you guys, for your education, because you're gonna be asked questions about secondary hypertension. But also I want to give you clinical hints. In other words, on your boards they may give you a very young woman with very high blood pressure, and you think about what condition?
Renal artery stenosis.
With what type of renal artery stenosis?
Like fibromuscular.
Fibromuscular dysplasia. Where is the obstruction for those patients? Is it in the proximal renal artery, in the mid or distal?
I'm not sure.
Okay, so the way to remember this is we have 2 different types of renovascular hypertension. One is the atherosclerotic renal artery stenosis. That's an old person's disease, or that's someone who has either a familial dyslipidemia or someone with bad nephrotic syndrome with accelerated atherosclerosis. But the way I want you to remember is like imagine a bunch of plaque forming in the aorta, extending into the renal arteries. If you remember that, you're never going to forget that the atherosclerotic renal artery stenosis occurs in the proximal third. Versus fibromuscular dysplasia, it usually happens in the mid or distal third of the renal artery. They may show you a picture, and the fibromuscular dysplasia it looks very different in a renal angiogram than the atherosclerotic plaque. The plaque is a narrowing, the other one is just like, I don't know how to explain it, but you can actually see like a tissue proliferation in the mid or distal, the third of the artery. And they always give you, they're very fair, they're not gonna trick you, they give you a young person. So why can you get that? What's the etiology of this fibromuscular dysplasia? Most of the cases are idiopathic, but I wanted to make you aware that we have more and more cancer survivors, and kids that, for instance, got total abdominal radiation, surviving cancer, they can develop renovascular hypertension. Somebody with severe abdominal trauma, they can develop renal vascular hypertension from scarring. Like some other weird conditions like retroperitoneal fibrosis, they can develop renal vascular hypertension. So that's for instance a classic question. They may give you a case of a patient with aortic coarctation. What is the association of aortic coarctation?
Upper extremity, high blood pressure.
Right, but what kind of disease, systemic disease, it's a genetic disease associated with coarctation of the aorta?
Down syndrome.
Almost. Yeah.
Just all your trisomies?
Turner syndrome.
Turner's right.
Remember?
Yeah.
So how do you diagnose it? You check blood pressure in the arms and the legs, because the coarctation happens in the thoracic aorta somewhere. Okay, that's how you diagnose it, okay? So other disease associations, they may give you a patient with like sleep apnea. Let's talk about sleep apnea. So who gets sleep apnea?
Obese.
Can you get it if you're not obese? For sure. But your pretest probability of someone having a sleep apnea is pretty high if the patient is obese. What are the questions you want to ask?
Snoring.
Who do you ask, the patient or the partner? The spouse. What else?
Like daytime napping. Yeah.
What else? One of the most sensitive questions for sleep apnea. Daily headaches. The patients get a lot of headaches. And how do you diagnose sleep apnea?
Sleep study.
You do a sleep study, and you guys know the definition, how many apnea, hypopnea episodes? So from 0 to 10 is like mild, from 10 to 20 is moderate, anything greater than 20 is severe sleep apnea. And when I was doing my reading about this entity, I was kind of disappointed, because a lot of the doctors put a lot of emphasis on hypertension and sleep apnea, but even when you successfully treat sleep apnea, the percentage of correction of the blood pressure is lame. It's only like 5 millimeters of mercury at the best. So don't put your money on correction of sleep apnea. If the patient successfully gets the sleep apnea treated and is still hypertensive, it's actually expected. So a lot of doctors say like, oh, this did nothing. That's probably more likely that's going to happen. However, doesn't mean that you don't need to screen for sleep apnea, because sleep apnea is a serious disease. More and more research is linking sleep apnea with development of not clots, but
I was thinking like car accidents and stuff like that.
automobile, yeah, decreased quality of life, like serious motor vehicle accidents. What else? Pulmonary hypertension,
Right.
and increased risk of cardiovascular and cerebrovascular events. That's why we have to treat it. You shouldn't ignore it. But the take-home message for you guys is like, don't put all your money that the sleep apnea or the CPAP is going to cure the patient's hypertension. Okay? Very good. Okay. Another thing I wanna teach you about sleep apnea is the fact that patients with sleep apnea, you can recognize them by looking at the labs. And these patients, most of them, they have a post-hypercapnic metabolic alkalosis. If you look at the bicarb, it's usually high. Let's say that you see a patient in clinic for the first time and you look at the labs and the bicarb is 32, and the patient is not on a diuretic, and you don't really have a clear explanation why the bicarb is so high. Sleep apnea until proven otherwise. So that's another hint that you can think about.
It's alkalosis?
Yeah. Remember, like chronic respiratory acidosis, so the kidney compensating is retaining bicarb. And another feature in the physical exam on these patients is that they always have edema. And the edema comes from renal bicarbonate reclamation. And when you reclaim bicarbonate, it comes along with water. So patients with uncontrolled sleep apnea always have pitting edema. That is not cardiogenic, it's not from the liver, you can say it's not nephrogenic, it's not from proteinuria, it's just from their body trying to compensate.
They have pitting edema?
They have pitting edema, yeah. Because they...
Respiratory acidosis and metabolic alkalosis, or just...
You get chronic respiratory acidosis, but the way you suspect it is the bicarb is elevated, because you have like a post-hypercapnic metabolic alkalosis. Remember, the lungs work like matter of seconds. The kidney takes hours to days. So in these patients, when you look at the labs, if you have an obese patient, just spend some time looking at the labs and you're like, oh wow, this guy's bicarbonate is probably 32. He probably has a sleep apnea nobody has recognized or treated. So I'm just trying to, teaching you to think, how to think as a nephrologist. That's what I'm trying to tell you.
Yeah.
So if you see that, that's a very good clinical hint. Okay, so yeah, so sleep apnea, bad disease, not a lot of hope that's gonna be the magic bullet to fix hypertension, but just think about it. Okay, so then we have a board favorite. Which condition is a board favorite for secondary hypertension? Okay, is it common?
No.
Is it common on your boards?
Yes.
You better believe it, right? So it's the most annoying thing. I've only seen 2 cases in my career, and one of the cases was my co-fellow when we were doing our transplant rotation at UCLA. She was having like all the symptoms, and she self-diagnosed. She was having all the symptoms. She was having palpitations, orthostasis, she was having flushing, she was having like headaches, she was feeling miserable, and she told me like, dude, I think I have a FEO. She did the screening test and it was positive. What's the screening test, by the way?
It's 24 hours.
No, it's actually an easier one. It's fractionated serum metanephrine. Fractionated serum metanephrine is easier. And if it's positive, obviously you go to the urine. And so if I tell you that the fractionated serum metanephrines are a little bit positive, is that consistent with FEO?
No, not really.
How positive do they need to be? Pretty positive. It's got to be like anywhere from 3 to 5 times the upper normal level. And a lot of the times you can get a false positive. If they give you a hard question, that's what I call like a nephrology level type of question. Let's say they give you like twice as elevated in a patient taking either clonidine or cocaine or TCA, a tricyclic antidepressant. So all of those things that I just mentioned can cause a falsely elevated fractionated serum metanephrine level. So the diagnosis is basically by excluding the list of false positive medicines is this long, but mostly it's like amphetamines, cocaine, ecstasy, clonidine, and TCAs. And if you exclude any of these meds, that can give you, reserpine also can give you that. If any of these meds, you exclude that and you actually confirm with the 24-hour urine the level is high, you need to look for the tumor. And you guys know the rule of 10, more or less, for FEO? 10% malignant, 10% extra adrenal. Yeah, 10% are just...
Isn't there like age too?
An age related, the older you are, I can't remember. But another thing that's important to remember is that this tumor has a pre-biochemical phase. And a lot of the times, I'm just saying, when it's diagnosed, when they do a CT scan for whatever reason, and the radiologists call it a FEO, you better believe this is a FEO. Because you're going to learn in radiology that it's a very irregular, cystic shaped mass that is almost pathognomonic. And a lot of the doctors, they fail to recognize, like let's say the radiologists call it a FEO. You give me that report and say like, let me measure. It's nothing, forget about it. There's a pre-biochemical phase, meaning that the mass is there and you need to monitor those patients like every 6 months. Because one of these days is going to start like releasing all these hormones. So FEO, another favorite question on your boards is that they love to give you those disease associations associated with FEO. So you guys remember MEN1, MEN2? So to this date, I always have a hard time memorizing which is which. My advice to you is the day before your boards, just grab the book, look at the table and memorize it, and then you can forget about it the next day. But I think the first one, FEO one, is like MEN1 is the 3 Ps. I think it's parathyroid, FEO, and pancreas, I think. And
Pituitary.
no, it's not pituitary, it's parathyroid, FEO, I think pancreas. Yeah, that's MEN1.
Organs, yeah.
Yeah, I don't know. That's what I'm telling you. I don't want to confuse you. I don't want to give you the wrong information. But my advice to you is grab a book. That's how I did it. The night before, you're not going to memorize this. And whenever I have a patient, I just look at it and say, okay, let me look for this, let me look for that. I recently had a pretty cool case of a patient with pancreatic, parathyroid, and he probably had men one. I might stop following him because I was just cross covering my colleague, but pretty cool case. So when you start thinking that way, you always remember that. Another common clinical scenario for FEO on your boards is that someone undergoing general anesthesia with severe hypertension. That's another way of presenting this condition. Another clinical scenario is that they have somebody with severe hypertension and the episodic hypertension, and they think that this lady is probably just crazy, and that's basically like orthostatic palpitations, flushing, and all those things are characteristics. So there is an entity. Not a lot of doctors know this, but there is an entity. I know because that's why I deal with a lot of complex hypertension, called pseudopheochromocytoma. Have you guys heard about it?
Yeah.
Okay, so pseudopheochromocytoma is syndrome that resembles the biochemical syndrome without having the biochemical excess of pheochromocytoma. And that's it's poorly understood what happens, but most of these patients are females and they have like an anxiety-mediated response causing severe hypertension. So I have 2 patients in my panel that I'm convinced they have pseudopheochromocytoma. There's no magic test. It's just a clinical diagnosis. But these patients, they present with normal blood pressure and boom, episodic, severe. You have a patient here?
Oh yeah,
Conrad.
yeah.
He probably has that. And most of the time
It goes up to like 190, then drops to like 50.
It was at 208.
right, it's
Okay.
probably
And I took
pseudopheo.
it manually, and it was down to like 160 something.
Yeah.
Like,
Is she anxious during the interaction, or
I'm sorry.
was she anxious during the interaction?
He has history of anxiety.
Yeah.
He takes bus. He has bus.
Yeah. What was the medication list?
He's tried everything. He tried all A's, beta, calcium.
No, but from psych meds. Did he had anything?
Currently,
Yeah.
just the Buspirone, which he hasn't started yet.
Yeah, he started that today, and then but otherwise, I mean,
sertraline too.
I don't think he'll stay on something long enough for it to be effective.
Okay. And do you know how to treat these patients?
For pseudo?
Mhm.
The anxiety.
And what else? You need to, it's a diagnosis of exclusion, meaning that you need to rule out other causes of secondary hypertension. And you need to explain everything, every step of the way to the patient, why you're doing what you're doing. And then at the end, when there's no explanation, you need to tell them what you think, that there's probably a component of like anxiety-mediated hypertension. If you don't explain to them, they're gonna take it the bad way. They're gonna think that you're telling me, you're accusing me that I'm crazy. And medications that are very effective to manage these patients are beta blockers. It's the drug of choice because of the calming effect. You know, we use beta blockers for stage anxiety and performance anxiety. So it seems to work pretty well for this type of population, which is obviously most doctors are not going to use it, because if you guys remember the JNC 8 recommendation, they said that don't use beta blockers as a solid therapy, but I dispute that statement, and this is actually a perfect example in when to use it. It's patients with suspected pseudopheochromocytoma. Okay, so pheo, not common in real life, common on your boards, okay? So other causes of secondary hypertension, so we have Conn syndrome. So who do you suspect Conn syndrome? But give me a vignette, like a clinical scenario.
You older?
Not really. You don't have to be old. Most of these patients are actually pretty old, pretty young. And that's one of the indications to do a secondary hypertension workup, is when somebody that's very young presenting with severe hypertension. So what causes aldosterone in the kidneys?
What causes it? Like ACTH?
What's the physiology of aldosterone in the kidneys? What does it do in the kidneys? If you have a lot of aldosterone.
Reabsorption of salt.
And what else?
Loses potassium.
Potassium wasting.
Yeah.
So you have a little bit of metabolic alkalosis, hypertension, and hypokalemia. So this is a classic triad. If you see that, it's mineralocorticoid excess until proven otherwise. Okay? So that's how you're going to be presented on the boards. They're not going to give you the other symptoms that are associated with this triad, which are like very numerous syndrome. We have apparent mineralocorticoid excess syndrome, we have glucocorticoid remediable hypertension, we have Little syndrome, we have Gordon syndrome. You know, we have like all these things that you don't need to know at your level of training, but for your level of training, you need to be very comfortable with primary hyperaldosteronism, also known as Con syndrome. Okay? So I'm gonna give you on the boards, young person with this triad. What do you do for those patients?
Give them aldosterone antagonists.
You're gonna treat them without diagnosing them? How do you diagnose them?
Diagnose them. You can look for the tumor itself.
That's the wrong answer. And they're gonna wanna trick you that way. You never, for both, for Theo, for hypophysis imaging, for adrenal imaging, you never do it unless you have documentation of biochemical excess of the hormone that you're looking for. So they love to trick people on the boards. Everybody, like, who doesn't want to just go ahead and do an adrenal MRI? It's the easiest thing, right?
Yeah.
But a lot of times we have like something called the incidentalomas. It's a pain in the butt because once you have that in your chart, you need to keep following. But the question is, why did you do that in the first place? So they want to teach you how to utilize resources wisely and efficiently. That's why the boards, they always want to trick everyone. So the screening test for, and remember this, when you read the question, my advice to you guys is when you read the question, I always read the first line and the last line. And I get an idea what is it they're asking me. Because sometimes they may ask you what is the next step in the management, or what is the most, or like the most important thing to do at this point. You know, they word it in a way that if you don't understand what they're asking, you're gonna mess it up. So the screening test for primary hyperaldo is, which one?
You just look for aldosterone, of course.
How? You look for aldosterone, but how do you look for it? What is the screening? I'm not telling the confirmatory test, but what is the screening test for primary hyperaldo?
Like another steroid?
Which one?
Some of the precursor steroid?
No, you're thinking about like, you're thinking the different path. I'm talking about the mineralocorticoid. You're thinking about the glucocorticoid. Huh?
Okay, ACTH screening?
No, ACTH is, remember, is when you have Cushing's.
Okay.
Right?
Renin.
What are we looking for?
Renin.
And what else?
The renin aldosterone.
There you go. So that's the screening test. Aldosterone over plasma renin activity. The way I remember it since I was a student and I never forgot it is, just look at my hand. R. Aldosterone in the numerator, renin in the denominator. Easy to remember, right? So you have to have both. Aldosterone greater than 15, the higher the more specific. Ratio greater than 20, the higher the more specific. If you have one or the other, it's just equivocal. We don't know what to do with that information. This disease is one of those things that there's no consensus in a way that, like for years and years, for decades, the American College of Endocrinology have been issuing the guidelines for management of this entity. But in reality, nephrologists are probably the one dealing with most of these patients. And the guidelines from the Endocrine Society were issued last in 2008. I don't think those guidelines are very adjusted to the reality, because if you have a patient, if you're consulted with a patient with severe hypertension or resistant hypertension, by the way, what's the definition of resistant hypertension? We didn't cover that.
3 different drugs that failed. You tried 3 different therapies that don't work.
Including what?
Thiazide, ACE, calcium channel.
So the definition is 3 drugs at maximum doses, including a diuretic. Or control with 4 drugs.
Okay.
Easy to remember, right? 3 drugs, maximum doses, including a diuretic, or 4 agents, controlled. Okay. So if you have a patient, going back to what I was just saying, if you have a patient with uncontrolled hypertension, and they come to you, and then the guideline says, like, if you're gonna do this aldosterone over renin, you have to get them off beta blockers, ACE inhibitors, calcium channel blockers, aldosterone antagonism, and you need to put these patients on verapamil, perhaps alpha methyl dopa, and I don't know what other dinosaur drug they recommend in that guideline. Who is gonna do that? I wouldn't do that. I wouldn't risk a patient having a stroke, like, oh, let's just come off all your medicines and just eat high sodium because I want to do the test. That's a mistake. So the best thing you can do is before you prescribe, definitely if the patient is on an ACE, ACE directly inhibits renin. Beta blockers, it directly inhibits renin. So depending on what you're targeting, you can have a false positive or a false negative. If you're attacking the aldosterone, you're going to have a false negative. I'm sorry, if you're attacking the denominator, if you're attacking the renin, you're going to have a false positive. So that's why it gets so confusing. But I think for your level of training, they're going to be fair. They're just going to tell you what is the screening test. You're going to answer aldosterone over renin. The next step is to do a confirmation of the diagnosis. And the confirmation of the diagnosis is done by obtaining a 24-hour urine for aldosterone. If the level is greater than 13, the higher, the more accurate, you have primary hyperaldo. And what do you do with that information at that point, Cable?
You start therapy?
No, you do the imaging. So at that point you do the imaging. And let's say that, what are you looking for when you ask the radiologist, how are you going to order the study? You're going to order, like, let's say adrenal MRI. What's the question for the radiologist? How are you going to write it for them?
High blood pressure, adrenal mass.
You're going to rule out adenoma or hyperplasia. That's how you're going to write it.
Okay.
Rule out adenoma or hyperplasia, right? So let's say that you did a MRI on me and I have one adenoma in the right adrenal gland. What do you want to do with that information?
So biopsy?
Send it to a surgeon.
And let's say that you take out my right adrenal gland and I'm still hypertensive. And you measure it again and my aldosterone is still pretty high. What are you going to do? You can send me for another adrenalectomy?
No.
You can't do that, right? So there is a test. For that reason, there is a test called adrenal vein sampling.
Okay.
You never, even if you have a mass or hyperplasia, you need to demonstrate that the biochemical excess is coming from that specific gland before you refer the patients for surgery. And if you confirm, let's say that yes, it's confirmed that gland is big and most of the aldosterone is coming from that gland, you can refer the patients to get surgically treated. But you need to disclose to them that only 65% of the patients will have either a cure or a reduction on the need for blood pressure medicines. A colleague of mine didn't disclose that to the patient. The patient